Good, even I can see from here now. So, osteoarthritis. We all know we see osteoarthritis so much day in and day out in other large joints like the knee and the hip. But we do see osteoarthritis commonly when we are doing sonographies, when patients are sent for arthralgias, sonography of the hand and wrist, and that is the time when instead of seeing inflammatory arthritis, we do see hand OAs. So that's the time when we realize that yes, osteoarthritis is not about just a wear and tear, but it's a whole joint disease where it involves cartilage degradation, synovitis, subchondral bone remodeling, degeneration of ligaments, and plus the capsular involvement. So all this leads to a significant amount of pain. And the patient usually doesn't realize this till he is in significant pain and disability. So the commonest joint affections which we see in our day-to-day practice when we are doing hand ultrasounds is we commonly see asymptomatic early first CMC joint OA. Then we do see deformities of the DIP joints where we see early OAs, moderate OAs, and severe OAs. Rarely do we see PIP joints, and the most rarely we do see MCP joints. So when the patient comes with a significant pain flare-up, we always think of giving relief to the patient, and that's the time when we think of intra-articular injections. We commonly give intra-articular injections in inflammatory arthropathies or inflammatory arthritis where the patient is on very high dose of biologics. But yes, intra-articular injections in osteoarthritis patients are usually given when there is significant pain in that particular joint which has swelled up and is kind of flared up. So we commonly give corticosteroids, and out of the corticosteroids, the Kenacort or the triamcinolone 1 is the one which we use very commonly. Then other agents like the viscose supplements like the hyaluronic acids are usually given in the larger joints along with steroids. So the steroid gives a short-term pain relief and the hyaluronic acid gives a longer-term pain relief. PRPs have been useful, but however, responses have not been adequately studied, and usually they are beneficial in younger patients with mild OA. So out of this particular molecule which has newly come up in the practice now, triamcinolone hexaacetonide, or hexa what they call, Kenacort hexa, is the one which we regularly use. It's almost half the dose of the triamcinolone acetonide, that is only 20 milligram, and it gives a longer action. So first CMC joint OA, what all do we see? We first see a joint which is widened. It is showing these degenerative osteophytes. So definitely we see little more than the X-ray, and we see widening of the joint space, early changes of OA here in the first CMC joint. That's the base of the first metacarpal, and that's the trapezium. So this is what we see, and when we put our probe pressure, this is done with a 20 megahertz probe. So normally the probes which we use, the wide footprint probes, linear probes which we use for our small part sonography or shoulder knee sonographies, that don't work here. You need to use a little higher frequency, small footprint or a hockey stick probe. This is the CMC joint where you see more of osteophytes. You can see the base of the first metacarpal which is really showing a lot of abnormal osteophytes, and then when you give probe pressure here, it gives significant tenderness. So that's the time when we know that yes, the patient has come for radial sided wrist pain, and the pain is because of CMC joint OA and it's not because of decurvance. And that's the time when we inform our physician or the surgeon that yes, this is what is happening. Then when it's grade 3 and grade 4, when there is significant osteophytes, completely rough surface of the joint, that's the time when the patient is in real bad shape, bad pain, and that's the time when you sometimes see inflammatory synovial thickening in the case of severe osteoarthritis. When you put Doppler, color Doppler, power Doppler on, nowadays our machines are having microvascular flow studies. So that is the time when we can pick up even a small flow, very slow flow, even lesser than what power Doppler picks up. That's the osteophyte, and that's the entire joint capsule. Then what we do is we give a local steroid injection where there is significant pain. Now this is the position which we typically use for giving a decurvance tendon sheath injection. So what we do is this probe which is here, small footprint probe, we keep it along the long axis of the first CMC joint so that we see the base of the first metacarpal and we see the trapezium, and then the angle of the needle should be in such that it goes into the joint. It should not be that the needle comes and hits this particular osteophyte and then you do an extra-articular injection rather than an intra-articular one. I think this was the video mostly, I think. It was a video. Yeah, it's playing, good. So now you see, I'm planning the needle approach from here. These are the osteophytes. I am seeing that there is no neurovascular bundle which is underneath my needle for getting injured. The thenar muscles are here. That's the tip of the needle. So first what I do is, if the patient is too apprehensive, with a small 26 gauge needle, I'll give a local anesthesia there, and then my needle will come here. Now you see the needle tip there. I'm trying to poke it and then I insert into the joint space. So it all depends upon the entire length of the needle should be coming under the probe, so you can see the entire needle going there, and then you inject a little dose, one drop of the dose and see, and then you can see that the joint is filling up slowly now. So once the joint fills up slowly, it distends. When it distends, the patient gets a lot of pain because the pressure inside the joint increases. So that's when you have to realize that these joints are of small capacity. If there is a lot of arthritis for a long time, the joint capacity increases. You can inject around 1.5 ml max. Otherwise, even 1 ml is good enough. So what we do is, we take 1 ml of steroid, mix it with 0.25 ml of 2% lignocaine, and inject only half the dose first. See how much patient can bear it. Don't inject it forcibly to tear the capsule, but inject it good enough so that the capsule distends nicely. Now this is the same patient who came second year for the injection, and now I have a different approach because this osteophyte is coming in the way and I can't put the needle from the proximal aspect. I have to go from the distal aspect. So I go over the head of metacarpal and I just click this. Yeah. Now you can see the needle will come from here. In this video, my angle is a little better, so I'll be able to see the needle in a better shape. Okay? So the needle comes here. The bevel of the needle has to be pointing towards your probe. And then as you enter the joint, nice joint recess, you can see the lumen of the needle also very well. And that's the time when you know that you are sure in the joint. The needle tip is in the joint. That is the time when you inject. And after you inject, once the dose spreads all over, you will be able to notice the exact amount of cartilage thickness which this joint has, the amount of osteophytes and the rough surface which this joint shows. Now you'll see slowly distension of the capsule. Already 1 ml or 0.5 ml, more than 0.5 ml has gone in. And there you can see these osteophytes there. These are the thenar muscles on top. So inject till the patient gets a little more pressure and that's it, leave it be. Now after the dose has been injected, you can confirm that yes, it's intra-articular. You just roll your probe after removing the needle, flex and extend the thumb so that you can see the adequate spread of the dose into the joint, and you confirm that there is no extra-articular injection or any injury to any neurovascular structure. This was an unusual case where the patient had a lot of pain at the thumb base. There were degenerative changes at the base of the first metacarpal, but in addition to that, there was abnormal soft tissue in the first CMC joint recess, and this was heterogeneous. So something like a chronic inflammatory or infective synovial tissue. And when you put Doppler, it's showing intense vascularity. So when something like this is there, before giving a steroid injection, you have to rule out an infection or an inflammation, and that's the time when you have to do microbiological investigations for this. So then what we did was, we did a core biopsy of the synovium, and this turned out to be tuberculosis. So first what we do is, we give a local anesthetic injection adjacent to the CMC joint from where the biopsy gun comes in. So this is done with a 26 gauge needle there. That's a very small needle, and you inject local here, then take a small cut here, and then the main biopsy gun comes, and you can take around 8 to 9 cores. So we take around 8 to 9 cores, 11 millimeter each width, and then we send it for gene expert, TB culture, and other microbiological investigations. Only thing is that you should know how much this width is. You should not take a gun which has a longer throw of 2 centimeters, otherwise you'll injure the normal structures. So 11 millimeter throw is good enough. Then we go to small joint, small finger joint OA, out of which DIP is the commonest. PIP also we see involvement in OAs. So this is the DIP joint where you see a mild OA where the joint space has decreased. You can see there is osteophytes developing at the base of the distal phalanx. Here they are covering the joint space, and it is grade 2. And here the joint gets destroyed, and that's the time when it gets subluxed, and you see those Herbert's nodes. PIP joint early OA, you see those cortical irregularities. And then you have this grade 2 OA of the PIP with inflammatory, little inflammation in the joint, but more so inflammation around the tendon. And that's what, when Dr. Balkrishnan asked the question, I had in my mind that I was showing a few cases. So this is what we see commonly nowadays in cases of OA, where there is tendons where they insert, there is inflammatory enthesopathy, there is tenosynovitis, which we do see. And you see, this is the second case where you see intense vascularity, intense inflammation in the peritendinous area where the central band inserts on the base of the middle phalanx. Now this was, so I have shown you the cases of OA. Now let me show you how inflammatory arthritis picture appears. This is the case of rheumatoid arthritis. You see the PIP joint involvement. That's the central band which is slightly thickened. That's the inflamed synovium and the effusion in the joint. You see the vascularity in the synovium. That's in the short axis, central band, lateral bands, and the fluid and the synovium. Vascularity. That's in the volar recess. You see the volar plate getting lifted up. In the volar recess, you see the inflammatory synovium. And then when you do the dynamic evaluation, sorry. So this is, that was not playing, so I'll try this. So then what we do is, whether it's a PIP joint OA or an inflammatory OA, if the patient is in significant pain, then this is the way of giving an injection in the PIP joint. We don't go on the volar side because the neurovascular bundles are there, but we go in a transverse plane underneath the extensor tendon apparatus. So this is my extensor tendon apparatus, this is the joint space, and that's the base of the middle phalanx. So let me hope that this video works, and yes, it's working. So that's a 22 gauge needle, and once you give local anesthesia here, you go in the joint and then slowly release the dose and see the nice spread of injectate on either side of the joint. And now you see the cartilage, how much eroded it is because of the inflammatory arthritis. So yes, this is inflammatory arthritis where we definitely give injections in flare-ups, but in OAs where there is significant inflammation because of and pain because of the erosions, we can give if the joint space is a little preserved. See this case now. This patient had gone to a surgeon for right index finger base pain. Now without doing any imaging, there was a local steroid given, probably blindly, for a trigger. And then after 1 year he has come, the pain is not resolved. So what you see here is there is some thickening of the A1 pulley at the finger base. It's 0.7 millimeters. Normal pulley thickness is 0.3 millimeters. But what you see here is there is some inflammatory tissue in the MCP joint volar recess. This is the volar plate. And when you see the dorsal aspect of the same joint, you see osteophytes, you see inflammatory synovial tissue. It is showing vascularity on Doppler. And then when you do a dynamic evaluation on the flexor side, these are the FDS and the FDP tendons. That's the head of the metacarpal, that's the base of the proximal phalanx, volar plate. This is the inflammatory synovial tissue. And let's see if this video works. Oops.
Dr. Ashwin,
Yeah.
1 minute more.
Yeah,
Next.
yeah.
Thank you.
Done. So this showed inflammatory synovitis and arthritis. So important thing to convey was that this was not a trigger, but it was MCP joint, osteoarthritis, maybe post-traumatic in nature, because otherwise it's very rare. And that's why an imaging is needed prior to this. Wrist injections are not given in OA because OA never happens in the wrist, but this is the way to give in the radiocarpal joint between the compartment 2 and 4 tendons. Then you have your whole set of the tendon sheath injections where in OA you get decurvans, that's the thickened retinaculum, and these are the APL and EPB tendons. That's the impingement which happens, and that's the way you inject. So the needle goes into the sheath. You see to it that you don't give it within the tendon substance. You make your way between the tendon and the retinaculum and then release the dose and then see it in both short and long axis that it is adequately spread throughout the sheath. Then there are decurvans with selective EPB involvements. So decurvans, if you don't do imaging, you can miss out on this, and this is the case which needs a surgery for treatment because local steroid injections in selective EPB compartment involvements usually don't work unless and until the patient doesn't want to undergo a surgery. Similar case, dorso-ulnar wrist pain, ECU compartment involved. Again, you give tendon sheath injections in the ECU compartment, taking care that you are not giving it within the tendon substance. So after injection, you confirm that the dose has been spread adequately till the base of the 5th metacarpal where the ECU inserts.
Dr. Ashwin.
Yeah, I'm done. Last
Thank
slide.
you.
So that's the trigger injection which we give in a case of OA, where the needle goes underneath the thickened A1 pulley and you can inject the dose. So you can see the neurovascular bundles here. That's the digital artery and the nerve. Here, there's the digital artery and the nerve. This is the one which we have to take care and avoid. So summarizing, OA of small joints is usually seen on sonography when patients are getting evaluated for arthralgias to rule out inflammatory arthritis. We do see inflammatory synovitis and changes, and accordingly we have to report. Now, first CMC joint is the commonly involved joint, and the DIP is the second commonest. Corticosteroids, when you give at the right time, give immediate pain relief, and the patient is happy after 1 week of the injection. Coexisting tendon pathologies can also be accurately injected and treated non-surgically. And the most important thing is regular mobilization has to be taught to the patient so that he maintains his long-term function. Thank you very much.